Dr. Schlesinger is a practicing nephrologist and managing physician at Rocky Mountain Kidney Care. He grew up in Los Angeles and UC San Diego and earned his MD at Vanderbilt. He completed his residency in internal medicine in Texas and trained in nephrology in Colorado. You get around, Dr. Schlesinger. His focus on treating kidney disease and hypertension. Dr. Schlesinger has held leadership roles, including medical director of dialysis units and vice president of clinical affairs for U.S. Renal Care. With a commitment to improving patient care outside of work, he enjoys spending time with his family and pets, and I think he has a lot of dogs, so we're going to be friends, as well as biking and hiking. So I'm really excited to meet Dr. Schlesinger. He's going to speak about stay ahead, preventing, and delaying kidney disease. So welcome to Hope Week, Dr. Schlesinger.
Again, I'm excited to be here, and I want to thank you for inviting me to speak. It's a fantastic topic that you chose for me, and I'm excited to share it with you. It's a lot more fun in the last few years to talk about this topic as well, because the therapies are better and they make a huge difference. And so that's one of the things that I do want to share, is that these therapies are now better. I'm going to take that as a progression of kidney failure. And the first things we want to discuss before discussing the new therapies is the prevalence of renal failure, how big an issue it is, what the kidney does, mechanisms of disease, and then the treatments that I'm so excited to share with you. So when I was first asked to speak, I went into the office of one of my partners and talked to a couple of them, and I said, I could do this talk in one slide and in 2 minutes. Eat well, control your blood pressure, take ACE inhibitors, SGLT2s, and GLP-1s. Done. And they said, you better put that on the slide. So I did. So if you take home any key points from this conversation, it's eating well, eating healthy, controlling your blood pressure, and we'll talk about that, getting it down if you're diabetic to under 120/80, and then to non-diabetic, there's a range of blood pressures that have been studied. Probably somewhere under 130/89 is appropriate. And then taking the 3 medications that I'll talk about in just a few moments. And I'll address each of these as we move forward. So first of all, let's define how big a problem it is. And it is a big problem in the US and worldwide. The burden of illness in the US is probably somewhere between 30 and 40 million people who have kidney failure of some degree, stage 3, 4, or 5. So what we're talking about is disproportionately affecting Blacks and Hispanics. So over 15 to 20% of Blacks are affected, and 15% of Hispanics, 13% of the adult population overall. It disproportionately affects people who are socially disadvantaged, who live in food deserts, can't get to healthy food, can't get to health care, can't get the medications that I alluded to at the very beginning, and it requires expensive care, again, if you're socially disadvantaged, that you often can't afford. This is being driven by the obesity epidemic in the US. Diabetes and hypertension are the leading cause of kidney failure. And what I want to show here is that this problem is getting worse. If you look back to 1994 with obesity, everything was in blue, kind of under 15% nationally. Moving to 2020 to 2010, or 2000 to 2010, it was over 25% of the population was obese.
I think you're dropping out. Is everybody, can they hear him, or is it me dropping out?
No, I think he froze.
Okay, so while he comes back, we probably need to share his slides. Maybe his computer's being cranky today. And so I think this chart is quite fascinating if we look at it right over time. Like, and I think there, oh, he just got kicked off.
He's
Hello,
probably
everyone.
going to,
Awesome, wonderful, thank you. So most of us are born with two kidneys. Each has about 1 million filter units called nephrons. This gives you a large functional reserve. The beauty of a large functional reserve is wonderful people in your life can donate kidneys and they can do well their entire life as well. The other positive is you can undergo a lot of damage to your kidneys and not notice and not have a problem. However, the negative, the other side of that coin, is that once you come to notice that you have kidney failure, you have often had a lot of damage undergone. So let's talk about what the kidneys do. We all know that they make urine. How much urine is made is determined by how much volume is in your blood vessels and your blood pressure. If you drink a lot of fluid, you make a lot more urine. If you go on a long hike and you don't bring enough water, then you will not make nearly as much urine. So they're very good at regulating that. And they're good at regulating both fluid and blood pressure. You have three components of blood pressure. You can beat your heart faster and stronger. You can constrict and open your blood vessels, and your kidney can take care of water. The first two, the heart and the blood vessels, constrict or work harder and pump harder when you're running in a race, being chased by a bear, or presenting in front of a bunch of people that you don't know. The kidney is the long-term arbiter of controlling your blood pressure, and by taking out the right amount of fluid or leaving the right amount of fluid in. It also regulates your electrolytes, which are very important because, for example, sodium and potassium, two of the electrolytes, deal with the electrical currents on your muscles and your nerves. And if they don't work, your muscles and your nerves don't work, including your heart. Other electrolytes, like calcium and phosphorus, are important in bone health, and they take care of making sure your bones are strong. And if it's dysregulated, it can actually harden your arteries rather than your bones. You already know from what Lori was talking about earlier, it gets rid of metabolic wastes. And so if they don't do that, you don't feel as well as she was discussing, and it removes toxins. Finally, one of the things that the kidneys does is it regulates anemia in your body. And the reason it does this is because to regulate anemia appropriately, you need to know the concentration of the red cells in your blood vessels, but you also need to know if you just drink a bunch of water and your blood vessels are expanded, or if you just went on a long hike and your blood vessels are contracted. And one of the few places that can measure both the concentration of the red cells and how big or small the vessels are is in the kidney. So it then tells the bone marrow how much to make. Let's go to the next slide, please. So if kidney disease is asymptomatic until people have advanced disease, how do you catch this and intervene early? And the answer is labs. The one most people are familiar with is creatinine. When people come to my office, people often confuse creatinine with creatine. Creatine is an energy source to replenish your muscles. When it breaks down and your body's ready to get rid of it, it turns it into creatinine and it's filtered out by the kidney. In general, you make about the same amount of creatinine every day, and you get rid of the same amount every day. However, if your kidneys get worse, the level of your creatinine has to rise in your bloodstream in order to get rid of the same amount. So your doctor or your lab or your other providers can tell what your kidney function is by that level of creatinine. It's not a perfect lab, and there are some drawbacks, but it is a nice baseline measure. The other lab that we don't talk about nearly enough, and I would love to increase awareness for, and that's the take home from this slide, is urine protein or urine albumin. Usually your kidneys keep most, if not all of the albumin in the blood and don't let it through the kidney filter. It's when the kidney filter is damaged, the nephron is damaged, that protein goes through. And the more, go ahead to the next slide, please. And the more protein that goes through, the worse it is. On the left panel here, I have a slide called Freedom from All-Cause Death, which is a big deal, right? And so what you can see in that red arrow going down more quickly than the other two arrows, that's more protein. And as you go to less protein, you have less people passing away, more people living. So this is very underappreciated. And so the take home I want to give you is that you need to figure out, if you have kidney disease, how much protein you have. And the positive part is this makes it a target for intervention where we can help and we can get you better. But I want you to take home that protein is dangerous and it doesn't matter what the cause is. I've put here 3 different diseases: diabetes, hypertension, and people without disease, general population. And you can see a graph, the more down the arrow is, the more down the bar is, the faster people are losing kidney function. And it's the more protein in their urine every time that will help them know if they're losing kidney function. Go ahead to the next slide, please. So let's talk about a minute for why. And there are multiple reasons that are a little bit too complicated to go into why the kidney spills protein. But the way I think about it is the filter, it's a water filter that has a hose going in, the arterial, and a hose coming out. If you take that garden hose and you change it over to, go ahead and go back.
Oh, I'm sorry.
That's all right. If you change over that garden hose to a fire hose, you can imagine that you're going to do significant damage to that delicate filter, that water filter, and you're going to have protein spill. In the same way, on the back side, if you take the garden hose that's coming out of the filter and you crimp it really hard with your hand, you know if you unscrew it, there's a tremendous amount of back pressure. And that back pressure causes the kidney filter to also get damaged. So here we have another target of therapy, relaxing that pressure. All right, next slide, please. So let's talk about those therapies. First is diet. Sounds easy, but in my life and for my patients, I found this is really hard. It's like the hardest thing we do is diet, especially with all those commercials coming at you from Nabisco and Frito-Lay and all these delicious things. But for people in general, for diabetics, for hypertensives, for people with kidney disease, those aren't the best foods. The best foods are the ones when you walk around the outside of the grocery store. You start in the vegetable and fruit area, make your way over to the whole grains, to the meats and fish and chicken, over to the eggs and a little bit of dairy, and on your way out. The problem I have is I get stuck looking at the Ben & Jerry's or the Fritos or whatever, and those aren't great for you. You want to eat food that comes from plants, not that's made in plants. I've been talking about diet for about 30 years since I became a physician. And I came across this line about 4 or 5 years ago, and I thought it was amazing. Eat food, not too much, mostly plants. I wish I could take credit for it, but it was written by Michael Pollan, who's a prolific writer on food. This sums up every diet I can think of in a nutshell. And it particularly sums up a kidney-friendly diet. It limits salt. Salt causes high blood pressure, particularly if you get over 5.5 grams per day. And we know there's a mortality benefit for eating less salt than that. That high salt causes more heart attacks, more heart failure, more strokes, all things we want to avoid. It's a moderate protein diet if you spend more time in the fruit and vegetable aisle, because the protein changes that garden hose that we were talking about in the artery to a fire hose and does more damage to the kidney. If you're doing it without kidney disease, it tends to be okay. But if you have kidney disease and you're trying to protect those precious filter units, you really want to moderate your protein. You also want to limit your processed and preserved food. The issue with processed and preserved food, besides the salt, is phosphorus. They use phosphorus to preserve just about anything in the form of sodium phosphate. That is very easily available for your gut to digest, bring into your body, increase and combine with the calcium in your body, that phosphorus, and harden your arteries, which is what also leads to heart attacks, heart failure, strokes. And so we want to avoid that. In contrast, you'll hear that vegetables are also full of a lot of phosphorus, and it's true, but it's not nearly as bioavailable. It's complex, it's inside the cells, and it's more difficult to get out, and you only absorb about half. People with the renal diet are often talked to about their potassium being high. That happens in later stages of kidney disease, and we do have to change from pomegranate juice or oranges over to apples or pears, but there are tremendous amounts of foods that are still available that avoid a high potassium diet. Go ahead to the next slide, please. Thank you. All right, so I put on that slide 3 things: blood pressure, eat right, take meds. Here's the blood pressure section. Blood pressure control leads to less death, less heart attack, less stroke, less heart failure. Same as eating a proper diet. And the right numbers matter. The goal for diabetics is probably under 120 on the top number and under 80 on the bottom number. The goal for non-diabetics is controversial and probably goes up from that 120 number all the way up to 130 or below, and on the bottom number probably up to 89 and below. And you can get away with many less adverse outcomes. And here you can see a paper from about a decade ago where you see the blue line, which is where people were under regular blood pressure control, versus intense line on the intense blood pressure on the yellow line. And they had less heart attacks, strokes, death, less death from any cause on that yellow line compared to that blue line. And you definitely want to be on that yellow line. Go ahead to the next slide, please. So blood pressures of 120 over 80. All right, the next one is an old medication. This study is from 30 years ago. And it had a ridiculously complex graph that I had on here first, or a table. I took it out, and I hope these 2 graphs do it justice. The other part of how ridiculous this was is how ridiculously good these medications are for people with kidney disease. These studies started with a couple hundred people on captopril, an ACE inhibitor, which I'll talk about in a second, and a couple hundred people without. They followed it out for 4 years. 50% of the people not on captopril ended up passing away, needing a transplant, or on dialysis. Half that many on the captopril got that far. They did much better. 50% reduction in death, dialysis, and transplant. That is huge. That saves years and years of life for people and makes a huge difference. The only problem I have with these meds is not enough people are on them. They're generic, they're cheap, but only about 50% of kidney disease patients are on it. And I think it should be 80 or 90%. Some people can't take it because their potassium gets too high on it. People have a cough they can't tolerate on medicines that end in a pril, or their lips swell and they can't take it. However, ACE inhibitors, captopril, enalapril, benazepril, lisinopril, things that you may have well heard of, have a cousin medication, things that end in sartan, losartan, candesartan, irbesartan. All those medications, you can still cause the high potassium, but don't have the same issue with the lip swelling, don't have the same issue with the annoying cough that people get on the medications that end in pril. And they all relax that artery and decrease the protein in the urine. Again, that under-recognized issue, the proteinuria. They also increase inflammation inside the kidney. So very good med. And importantly, even if you have that great blood pressure of 118 or 120 over 80, it can still help you if you have kidney disease or heart disease and decrease your risks of death, dialysis, and transplant. So that is why I say even people with regular blood pressure should be on these if they have advanced kidney disease. Go ahead to the next slide, please. All right, these next medications that I'm talking to are called the SGLT2 inhibitors. And you have probably seen these commercials because they're everywhere. It is Farxiga and Jardiance, where they're dancing and singing about controlling their diabetes. You do not need to be diabetic to take these medications and do great with them. They will keep people off dialysis the way that captopril, not the way, by a different mechanism, by a different way. So they're additive and they work in conjunction with those ACE inhibitors or those medications that ondansetron, the angiotensin receptor blockers. And on studies, they decrease death, progression to dialysis, loss of kidney function, heart failure, hospitalization. These are all things that we all know we want to avoid, and these medications do it. And they're covered well now by insurance. But the trick is that only one of these medications is going to be covered by insurance, either the Jardiance or the Farxiga or something else that's similar. And so if your doc gives you the script for the medication that's not covered, when you go to the pharmacy, they say $500, please. And you say, that's a quarter of what I make in a month. And what I tell my patients is ask your pharmacist to call back the doctor's office and change it to the one that's covered. The doctor can't always see what's covered, but the pharmacist can. And they can tell you what's covered and they can help get it switched and my patients get this medication. I've shown this slide specifically because what I want to show is the patients on this medication are in the yellow. And what you can see is their function drops initially. And this is scary to people. And it makes them want to stop the medication. This is normal. When you relax the pressure in the kidney, your creatinine is going to go up. This is not only true of these medications. This is also true of those medications I talked about in the last slide. The ACE inhibitors, the lisinopril, the captopril, the losartan, the candesartan. All of these medications will make your creatinine go up a little bit, but it will so dramatically slow the loss of kidney function if you stay on them for a few years that those paths cross, and you do much better if you stay on these medications than if you were off them. And the loss of function, if you add in the ACE inhibitors, the lisinopril medications, and these medications, the liflozins, things like Jardiance and Farxiga, if you add those in together, you can get your loss of function down to 2 or 2.5% per year. Everybody loses kidney function a little bit. Everybody loses 1% per year on average. People with diabetes with uncontrolled blood pressure will lose it at a couple percent per month and then about dialysis in a couple years. These medications can keep you off dialysis for years and years and years. Go ahead to the next slide. The last medication I want to talk about is kind of all the rage nowadays, and it's the medications like Ozempic, usually ending in glutide. Semaglutide is Ozempic or Wegovy, or tirzepatide, which is Mounjaro. And so these are very popular. Other medications in the class that work but aren't as strong are things like Trulicity or Victoza that people may be on if they're diabetics. A study just came out in April, which I sent here, and you can see that same issue where people on that slide of the graph lose function more slowly than people who weren't on the medication. And so they were down with this medication and others down to 1.2 milliliters per minute per year of loss of function. So that means if you're a diabetic with risk of going on dialysis and your function is 30%, with this medication and the captopril or losartan and the Farxiga or Jardiance, you can get your loss of function down to where it can be 10, 15, even 20 years in the future. This is life-changing and amazing. It used to be 3 years, 4 years. Getting 16 extra years off dialysis gets you to the point where you get one transplant and that lasts you the remainder of your life. It goes the next 20 or 30 years. So this, I think, is a really special time because this study came out 4 months ago, and the studies on the medications on the last slide came out 4 years ago. So this is all new since then. And I am trying to get as many of my patients on these medications as possible, and I'm seeing the difference already. Go ahead to the next slide. Thank you. All right, so the take-home message again, eat well, less salt, less phosphates, eating around the edge of the grocery store, right? Mostly plants, not too much. Controlling your blood pressure. Again, those magic numbers are somewhere between 120 to 130 on the top number, and certainly less than 90 on the bottom number. If you're diabetic, probably less than 80 on the bottom number. And these 3 types of medications. The RAS inhibitors are those medications like ACE inhibitors, lisinopril, things that end in pril, captopril, enalapril, and the sartans, the angiotensin receptor blockers is their formal name, things that end in sartan, losartan, irbesartan, candesartan. There are lots of generics. They're not expensive. They're easy to get on. Unfortunately, the SGLT2s are a lot more expensive. Those are medications like Farxiga and Jardiance I talked about. And then the GLP-1s, we have a huge variety. Semaglutide has the best studies. That's the Wegovy or Ozempic, has the best studies and the best results. I'm not a drug salesman. I don't work for any of the drug companies, but that drug is a miracle, as is Mounjaro. But Mounjaro does not yet have the studies that show all the same benefits. I think it's the same, but I can't promise you that. So I think both of those medications are life-changing.